Now, I will request Professor R A Sastry from Hyderabad, who has been the chair of surgical gastroenterology at KIMS Hospital, Hyderabad. Earlier, he was in Nizams, and he will be speaking on GI cancers in the domain of surgical gastroenterologists, making the difference in outcome. And before that, he will be paying tribute to the departed soul, Professor S.P. Kaushik. Shastri, please.
Good evening. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. It is an emotional travel for me, coming all the way from Hyderabad, reminding me of my 50 years, nearly 45, 50 years of my journey, which had started here. I must compliment the GI surgery department here for commemorating the two stalwarts who had adorned the department here and who were my teachers and mentors for the past 4 decades. Professor Kaushik, I'll have to go back even before what Dr. Vinay was referring to. Many of you probably would not know that Dr. Kaushik had started his career in Jipmar, Pondicherry, where I did my MBBS. So my association with Professor Kaushik dates back to 1969, 52 years. Of course, I was too junior to appreciate what the person was, only used to look at him with awe. Followed him closely as he went with PGI. I had followed him too. And in 75, when I had joined PGI, 75 to 81, I had spent 6 years of my most precious life, which had shaped me to what I am today. Thanks to the 6 illustrious teachers of mine, whom I don't think I can ever forget, and I've been in contact with PGI, and all the teachers of mine have been in contact with me. That speaks volumes of their mentorship. Professor Kaushik, when I did not work very closely with him. All along, all the 6 years I had worked with Professor Talwar. But Professor Kaushik had a soft corner for people from Pondicherry, from Jipma, and from the South in general. He was one of those people who the necklace was referring to, who would see a clinical question in each patient. That is what had impressed us those days. Be it an acid peptic disease or a gallstone or amoebic typhlitis, which was people were very fond of those days. We were all asked to take rectal samples for all the right iliac fossa pains to look for EH, to see whether there is an associated amoebic typhlitis, because that was a clinical question he wanted to look into. There were a few problems I don't think I would get into, but then the rounds, which the grand rounds on Saturday, the questions from Professor Kaushik used to be such thought-provoking that you had to go back and look up the answers to them, which was only through Index Medicus. We did not have internet those days. Now, Professor Talwar, although the association was more recent, but it was much more prolonged and much more closer than Professor Kaushik, can still forget. Pardon me for if I get into a little emotional thing for a few minutes before I start the topic I was assigned to. January 1st week, 1975, my entry into PGI male surgical ward in the 5th floor, and the round day, and I was the first year junior resident. Dr. Salim, Dr. Chandrakanta were the senior residents. The chief enters the bed number 13, where the ward round starts, looks at me. What's your name? His name, of course, preceded his physical appearance. So we all knew how he was. And then in a diffident tone, I say, Shastri. And he, at the top of his voice, my name is Banarasi Lal Talwar. Every Indian has 2 names. Are you ashamed of your family name? And it doesn't stop there. Points to the window. Better you know what that window is for. To throw the errant house surgeon out. That was the reception we had on the very first day. Almost to the verge of thinking of quitting. But then there were other senior residents and the other residents who had much more experience with him, appeased me. And then you can listen to his voice here. I hope the volume is it the sound on? No, it's not on. Can you put, it has to be put on here, is it? No, it's all.
Professor for a lower crime, governor for a higher crime.
Well, it's just I have recordings of some of his homilies, which I had recorded almost every year of my visit to him. There were very few visits of mine to Chandigarh, which I had made probably 10, 15 times in these 25 years. And my visit would never complete unless I visit Professor Talwar and listen to his homilies, listen to his philosophy of life. And this is what I had posted when after one of my visits, which probably speaks of my own mind. A ferocious taskmaster of the old school, a terror among the resident community, a disciplinarian who believed in commanding respect and ethics and honesty personified. I doubt if any other resident had the luck and privilege of having all the first major operations assisted by him. That was his greatness. He made it a point to assist personally all the major surgeries which I had done as a senior resident. And it was not just the intricacies of surgery that were imparted. Not too much of theoretical knowledge either. He was not a theoretician at all. In fact, for some of his lectures, we had to prepare as senior residents and give it to him for giving a lecture. But the artistic and the holistic elements in surgical practice and simple practical tips which no textbook would ever teach. The ergonomics, And all the basic Halstadian principles of surgery that can never change are driven home right into your raw hands. That was the mentorship and the teaching we had with Professor Talwar, and which I remember. None of the theory of surgery. I had, he's not a very good net savvy person, although he always made it a point to communicate through emails. Almost every year I used to get some counseling from him. And when I had sent this posting of mine to him, look at the humility. I'm not very, the response he had, I'm not very computer savvy. Teacher and student relationship is dynamic in space and time. Now you are a teacher and I'm a student. That is the humility he had. And this is what I had learned from him, how to hold hands. He would teach when you visit a patient on the first postoperative day, you go with a smiling face, hold the patient's hand. That would give enormous amount of trust to the patient. That is half the battle with the patient. And that is what I had learned in the bedside management of a patient. This is how he would, I particularly put this picture to show how he would hold his hand and how he would hold my hand. Every year I visited him and spent an hour with him. These are the people who had shaped Professor Vig, Dr. Kaushik, Dr. Bose, and Dr. Talwar. And this was the department those days. The 6 people who had made all the difference to me in my 50 years of surgery. Let me now get into the topic that is assigned to, pardon me for the delay. I just couldn't leave the opportunity, and I'd come all the way from Hyderabad only to share the type of emotion. My wife always keeps saying, I see Talwar in you. My residents always say, who has influenced you in some of my outbursts, occasional outbursts. Now the topic is GI cancers in the domain of surgical gastroenterology and making the difference. Let us see what is the incidence of GI cancers. GI cancers in India is not a very common disease. Of all the cancers, it is a rare cancer. Although we don't have too much of data, Dr. Mohandas articles in Indian Society of in gastroenterology, ISD, and then his series of articles in Lancet Oncology, where there are articles which are worth reading, talk of the socio-economic influence on GI cancers, how the environmental factors in India probably make a difference, and how it makes a difference, how different is, say, the rectal cancer, particularly in the young in India, is different from the rest. Is the incidence increasing? We have a paper from this institute itself, which suggests that there may be an increase from 21 to 26% in over 10 years in GI cancers. Part of it is probably because of awareness. Part of it is because of the detection rate, not necessarily because of the actual increase in the incidence. We never know because we don't have the data. How much of GI cancers form a proportion of your GI surgery? I have data from 4 institutes. The data from Medanta and GEM is actually the data which is shared with the National Board of NBE from their accreditation. It's about 25% of GI surgeries, although it is quite variable, mostly because, as I had analyzed, it's because of the non-GI surgery component. which also makes some proportion of GI surgery, particularly the abdominal wall hernias, and then laparoscopic cholecystectomy, which forms a bulk of biliary surgery. If you remove this, it almost, say in NIMS, which have the authentic data, it's almost about 48% of GI surgery is GI cancer, almost half of it. Although in the other institutes, it's about 25-30%, but then it's very raw data. It just gives an idea of, so how do we make the difference in the outcomes of GI cancer? I've thought of and selected 10 areas, although I don't think I'll be able to deal with each of these. Like it or not, surgery is the mainstay of treatment in GI cancers. And in the conceivable future, it is going to be, in spite of all the advances in the other areas. It's probably, the timing may change. When exactly you would do the surgery, you may do with more finesse, we may do more organ preserving surgeries, but then surgery has to remain in the next few years as the mainstay of treatment in GI cancers, which gives us a tremendous responsibility, which we should take into our hands as the prime care giver. And we know it is a multidisciplinary treatment for cancers, like in many other areas. And as the prime caregiver, we need to be the leader of the team. And I think we are the most eligible because we have seen with experience the GI cancer live. It is not virtual. With your own eyes, how it evolves, how it spreads, how it affects a person, how it affects the society and the families. We are closely in touch with all these areas, and we as GI surgeons should be the leader of. And for that, it's not just enough to say I'm a GI surgeon and I have the responsibility or the eligibility to do GI cancer surgery. We have to be abreast in the advances in the knowledge and skills, which are mind-boggling in the areas of particularly imaging, genetics, immunology. And rationalize the treatment strategies. The various 3 or 4 types of treatment strategies we have to rationalize. We have to be aware of the challenges in that and try to overcome them. With the flooding of knowledge, explosion of knowledge, the gap between the knowledge and practice is increasing, and we have to find ways of bridging the gap. The enormous number of guidelines we have, the confusion we have in applying them, we need to learn to tailor those guidelines and practice evidence-informed surgery, not necessarily evidence-based. And keep the audit cycle on to improve constantly. Ultimately, you end up not just following evidence, but you help to create evidence. With that idea, I think we will make a lot of difference in the outcome of GI cancers. The role is modified in the past 2-3 decades, thanks to the advances in technology, improved and novel therapies. And it is going to be shaped by the knowledge, skill, and more importantly, the opportunity to capitalize on the unique position you have in the continuum of patient care. That is what you have to be aware of and follow. Now, this is, of course, the multidisciplinary care and how we need to lead the group. I'll just show you an example of the continuum of care on how you should get involved with all the other disciplines. The year was 2009, a 57-year-old female in a good performance status, no comorbidities, non-cirrhotic liver, presented with a large liver mass, a typical liver mass. The serum markers were negative. The secondary, is it a secondary upper GI endoscopy, and the search for a primary was negative. What do? That time we did not have any more investigations, and FNSE was done just for find out, although it is not necessary, nor is it advisable. And FNSE was a neuroendocrine tumor. We did not have the sophisticated imaging. Serum gastrin levels and some other, it was not a functioning tumor, but still it was normal. And chromogranin A was high. We did a right trisectionectomy because it's an operable tumor in a fit patient, and that is the standard treatment. And the histopathology is a metastatic neuroendocrine tumor. Primary is unknown. Now, this patient was followed for 9 years. She was asymptomatic for 10 years, and a master checkup, which was advised by an educated son, showed chromogranin A was high. And this time we did a FDG PET because all the other investigations were normal, and even FDG PET did not show anything. Now we have DOTATAC, and that showed an activity in the right iliac fossa and activity in the pancreas. We did a central pancreatectomy and ileocecal resection. We did a 5-HIAA, which was negative, and the histology is synchronous primaries in these two areas, presenting as a large liver secondary 10 years back. And this is the kind of zebras which you should be aware of as a GI surgeon. Not all is typical. Unless you apply your mind, you apply the technology, you will not be able to get into these. And the story has not ended there. Another 2 years, she has developed loose motions, and this time 5-HIAA is high. And another DOTATAC scan showed 1 centimeter avid area in the liver remnant and multiple sub-centimeter lesions in the peritoneum. The neuroendocrine tumor was a low-grade tumor. Now what? We have multiple ways. We have multidisciplinary meets and a PRRT or target therapies. Many therapies were suggested, and since it is functional, we opted for a long-acting octreotide, and her symptoms were relieved. And she is still under follow-up. Happy person. She has no problem, but she still has sub-centimeter secondaries in the liver, in the peritoneal cavity. Now, this is a kind. What it suggests is how a GI surgeon, as a leader, follows and involves the multidisciplinary team, involves the new technology, and deals with it. And now we have many GI cancers like that, even low rectal cancer. We have esophageal and stomach cancers where the guidelines have changed. Surgery is still the mainstay, but the timing is different. Genetics is another area, and the two areas which will expand the realm of surgical gastroenterologists would be the implications of genetics and epigenetics in GI tract cancers, and the more direct role of chemical and biological treatment of cancers we have to be aware of. And a cancer genome atlas network, which is mapped for colon cancers, it will give us an idea, and it will direct us in many areas: diagnostic, preventive, prognostic, and therapeutic approaches. And you have to be aware of all these. I'll just tell you, this is a cartoon which I'm sure many of us will have to learn, relearn, and tell our residents how the targeted therapies act at various stages of cancer, these 10 areas, and how they would act. Now, this is what I had, a WhatsApp call from a patient. Is there a stool DNA test to screen for colon cancer available? And he was already Googled, and I think not, but please let me know if you know of anything. After he had seen an ad for a stool DNA test, I had to really Google, I had to find out whether it's really happening in India, although you had an idea that such a thing is there, but anybody is doing it. Now, that is the kind of awareness which you will have to follow. And let's get into some more areas. I don't want to get into all these standard healthcare problems, which whenever you discuss the public health, these are the things which you would discuss, these 7 problems. But I would only concentrate on just 1 or 2. The quality of healthcare, particularly in cancers, and over-enthusiastic adoption of expensive interventions of low value, which you see so often in sophisticated centers dedicated for cancer. And before I define on how the quality is judged, what are those parameters which you should judge? We should form the parameters for your audit. Correct diagnosis, proper staging, proper risk assessment of the disease, the treatment, and the patient, and proper treatment, best evidence, best technology, best technique, and the outcome parameters, not just the survival complications and whether the disease is cured or not, but how the quality of life for the patient, the function restored, and when the death is inevitable, death with dignity. These are also the parameters which need to audit in your quality analysis. There are many challenges. Apart from the patient and the surgeon, there are plethora of guidelines which will confuse you. The infrastructural problems, the administration problems, and other external drivers, which are probably more important. Thanks to the exponential increase in the cost of healthcare, the third-party payers put a lot of brakes. Probably you may not have that experience in a public institution where you probably do not have dearth of funds. But then in many other places where you depend on insurance, the governmental and the private, the audits and the way you treat is guided by the amount the patient can spend or have the third party spend on him. The best practice approach may have to be resorted to. The threatening medical legal environment and the violence are, of course, the other drivers. A lot of us think that we practice evidence-based medicine, but the evidence is otherwise. Level 1 evidence is done in less than 24% of the patients, and 29% would not even follow level 2 evidence. Why is it so difficult to get good evidence in surgery? It's not just the practice, but to get evidence in surgery itself is difficult because the uncertainty about the overall benefit or harm offered by a treatment. It is uncertain because of the bias, because of difficulties in blinding in surgical patients, unlike in, say, when you are doing a drug trial. The learning curves are steep, and while you learn, your new technique has come. Difficulty in differentiating efficacy and effectiveness. Standardizing the technique is difficult. The way I do and the way others do are different. And we are not trained in epidemiology. So it is much less in surgery than in many other specialties. I'll not get into too much of these because of time. The plethora of guidelines. For cholangiocarcinoma, you have 10 guidelines. Why is it so difficult? Again, because this surgical training structure is apprentice. What Dr. Talwar did, I would do. What I would do, my residents would do for some time at least. But things are so changing so fast. And then the dogmatic approaches. If I say it very strongly that, see, this is the procedure I've been doing, and then I say it with confidence in a conference, many of the people would follow. Some people would also treat it as an affront to your autonomy. Why should I do? See, I have done hundreds of these and I have good results. There's no need for me to follow any of these. There are other barriers. In every conference, you would see people talking of, you people from cities do not understand our problems. The latest is the best. what starts off as a multidisciplinary care ends as a conflict of ideas. Different modalities of treatment give equal or equivocal results, and which one to follow? Aggressive treatment may be the best treatment. Obviously, good enough is not enough. So how do you bridge this? We all know knowledge is the enemy of disease. Without knowledge, the disease cannot be conquered. But too much of knowledge, and there is the gap between the knowledge and the practice keeps widening. Now, how to bridge that? It's important because you want to ensure safe, proven, and inexpensive interventions reach those in need. We know that those with needs have fewer means, and this reality needs to be overcome. What is the solution? You have to think out of the box. Implementations require change, but people and organizations do not like to change. That's a challenge. You also need to know the difference between a legal evidence and medical evidence. See, legal evidence, when you say evidence in law, it is based on evidence of one instance. You quote one instance and say, this is the evidence for this problem. Whereas our evidence is generalizable. It is not based on a single experience. So the generalizable evidence needs to be tailored to a single patient. That is our difficulty. Now, how do we tailor these guidelines? The guidelines need to be tailored, particularly in surgery, and they have to be tailored according to patients' needs, the infrastructural, the availability, and the socioeconomic environment. It is important not to insist on the best for a person. We have seen a lot of people who have gone bankrupt and with no matching outcomes. You need to balance the socioeconomic status with what is best available. Oh, sorry. Does tailoring knowledge diminish its value? The Cochrane summary says no. Interventions tailored to prospectively identified barriers are more likely to improve professional practice than no intervention or dissemination of pure guidelines. So what needs to be practiced is an integration of evidence-based information with the clinical expertise, the skills and experience adapted to a particular patient, a personalized treatment with the patient values, patient preference, and attitudes to overall management. So it should be more of an evidence-informed surgery than evidence-based. And that needs to be audited because it is not a standard accepted guideline. And unless you have a constant audit and involve an audit cycle, which is persistent, it is not just one-time audit. That needs to be done to enhance your perception of the treatment. So I think I'll stop here. Say the traditional surgeon who is stereotyped as aggressive, arrogant, cantankerous, and dominant, and he is a loner, should give way to a current day GI surgeon who is more practical, who is well informed, well organized, is decisive, but he is part of a team. This is what I would expect a GI surgeon to practice his GI cancer. And the GI surgery department here is extremely lucky to have the legacy of some of the stalwarts in the field. Although they were not part of a GI surgery, 45 years back, I've seen Whipples here, I've seen a liver resection here, I've seen multivisceral resections for cancer. No doubt they're done with more finesse. No doubt we know why we are doing it and we know how to manage the complications, but then the complications were too many, even those days. In fact, we had learned more number of complications here than the actual surgery in PGI time. That is a general impression. So the GI surgery department has that legacy here, and they've already made a mark. Although the department is just 1 year old, they've been at the job for the past few years, and I wish them all the best. And I think they have a great future. This is just the summary of the 10 points I have made. Thanks again for giving me this opportunity to share my emotions. Thank you all.
Thank you so much, sir. Please stay on. I think Dr. Vinay Kapoor, Dr. Pramod Garg are also the discussants. I'm not sure whether Dr. Mishra is also there. They may, like to discuss with you, and probably, are they online? Professor Kapoor and Professor Pramod Garg? Yeah, they are there. Professor Mishra is also there. So would you, yeah, all three are there. So they would like to discuss. Dr. Kapoor?
Yeah, I think we've been discussing this issue of the overlap between surgical gastroenterology and surgical oncology on one end, and between surgical gastroenterology and, I don't consider, but some people call it the specialty of minimal invasive surgery. So I think it is for institutions like AIIMS, PGI Chandigarh, SGPGI, and other institutions to kind of discuss these issues, sort out these issues, and issue some instructions or guidelines which our statutory bodies should probably then follow and implement.
These are contentious issues. Who is to do? There is bound to be some overlap in medicine. That is why I have, with certain amount of chauvinism for surgical gastroenterology, I've given the reasons how we should be the leaders and the criteria for becoming a leader. Then the requisites to become a leader in GI cancer care. Well, I think ultimately it is not the label of a person which decides the way you work, the amount of work you show, that would decide whether you are the exclusive caregiver in GI cancers. I don't think anybody can claim monopoly over disease. There's bound to be some overlap. And if a surgical oncologist has specialized in GI cancers alone, well, it's difficult to contest that. Whereas even for a GI surgeon, and he is doing right from esophagus to the rectum and the HPB surgery, and to qualify himself as a GI oncologist, but also can be questioned. So these are all the issues. And I think what is important is to decide on whether you want to specialize in a particular area. GI cancers is also a wide subject. The upper GI surgeon, the colorectal surgeon, and the HPB surgeon. So these are the three divisions ultimately I think surgical gastroenterologists will have to divide into, because an HPB surgeon and a colorectal surgeon have very little to do with each other. The concepts are different, physiology is different, anatomy is too far away. So the cancer, which is part of that, which is an integrated subject for anatomy, physiology, and the pathology, is bound to be different. So they ultimately the specialists in those three subdivisions would be the leaders in the cancers. I think that is a far-fetched area, but then I have no particular solution for this kind of conflict of who is to do GI cancers.
I don't think, Dr. Sastry, there is anything we have to do. Most of the times, it is the patient who will determine. And many changes in society and the way we care are compelled by the patients. And when they ask these questions, and you should be comfortable answering those questions, then that means is okay. My take on these things is, if you are doing reasonable volume of work, irrespective of what's your specialization or sub-specialization might be, it's fair to do, because what you want, the patient should not be harmed. There is no point in doing one procedure a year, even if you can do it technically. I think that is something which surgeons or doctors have to realize, that they actually need to refer, and referral should be liberal between the surgeons, between the various specialists and sub-specialists. There will always be overlap, like parotid, who should do it? ENT should do it, or general surgeon? If I can do it, I say I can do it, because it's an uncommon operation and everybody will have almost the same volume. But certain like Whipples, there is no point in doing one Whipple a year. If somebody is doing high volume of work, and there are specialization now between GI surgeons, somebody is a good upper GI surgeon, somebody is a good esophageal surgeon. So that preponderance will always be there. And that is why there is, in institutions, we have this liberty of calling our colleagues. For the training of residents, not necessarily I'll do a procedure, but I can always invite you or somebody whom I think is better than me in doing that, for the sake of residents, so that they are exposed. Particularly in general surgery training, when they are exposed, they may take their own decision what specialization they want to go for, whether surgical oncology, GI surgery, urology, pediatric surgery, or neurosurgery, or what, cardiothoracic surgery, or whatever. So I think patient should be, again, I would repeat, for every young surgeon, if they are sitting somewhere, the patient should be at the center. Surgery should not be done for Swanta Sukhai. Unless you are very sure that you can do it comfortably, safely, patient safety is the uppermost. And that is something, you know, your heart in heart, what is good for the patient. Don't please yourself. Of course, when you are getting trained, as was shown, that initially when you start doing a new procedure, it is going to take longer, and that happened with each one of us. But again, that now there are opportunities for training available. MCH training is available, DNB training is available. So that learning curve can be shortened, but still in surgery, experience does matter, and that will always be there. And because nowadays even courts ask, why did you do it? And they look for even small things. And I think few years ago, my health minister asked me, who is the expert in DVT? So these are also the questions which come. So I think it is up to us to be ethical, to be honest to the patient, to be transparent to the patient, and take care of the patient interest. Patient interest has to be uppermost. In my opinion, that will determine who should do it what.
But I think the reason we kept this talk was, like you said about carotid body tumor, you know, it comes into the domain of ENT surgeon, it comes into the domain of general surgeon, it also comes into the domain of vascular surgeon. So if it is a tumor, you know, a vascular surgeon probably of all these three would be better placed to tackle the complications of this disease, and maybe do a better job if he has to go even higher up towards the cranial side. So, you know, that's what we were discussing, that if it is a high local angiocarcinoma, a person who is doing liver transplant surgeon, would he be able to offer a better technical exercise, or whether a general surgeon or another surgeon who's not doing those other related surgeries which are complex offer the similar kind of results. So probably we think that a person who is doing a liver transplant, if he is doing high local angiocarcinoma, he'll deliver better results. So, I mean, that was the premise when we started this. This was the discussion we had, you know, in-house between us. So we thought we'll have the opinion of our experts. Dr. Adar Chaudhary is also here. And we also have the young faculty, young residents, and the, you know, pass outs, alumni. They can also, you know, chip in and give their own views. Dr. Adarsh, if you have to say anything.
To talk on a subject like this is very, very difficult. I absolutely enjoyed your talk. And I think talking on a subject like this needs a lot of mental dimension. And I think I really congratulate you. Absolutely enjoyed it.
My own advice for the GI surgery department, upcoming GI surgery departments is right now you start developing into the 3 divisions of GI surgery, the upper GI, colorectal and HVB. And then excel. Say each person or whoever is interested would develop that area of GI surgery. And then nobody can question you. Say if a colorectal surgeon starts doing cholangiocarcinoma, a person who is interested, who's been doing, has a lot of large volume of this, but then he gets a cholangiocarcinoma and then he wants to operate on that, definitely, although he's a GI surgeon, it's not fair. So you need to, particularly in academic institutes, you need to develop the 3 divisions, which are totally, ultimately they may develop into 3 separate specialties. But then at this moment, I think it's time to divide into these 3 areas and let people, give them opportunities to develop rather than fighting with your contemporaries, say the surgical oncologists.
Yeah, once to start doing one kind of work, automatically the patients will be referred to you, and those kind of patients
Exactly,
will be
yes.
automatically diverted to you. So it is better to develop one skill or one area of interest specialization and go forward in that.
Another issue, when you're looking for new faculty in GI surgery is how to find people interested in colorectal surgery or people who are interested in upper GI surgery. Most of the people want to do HPV surgery.
Things have changed, Rajesh. Things have changed. With the advent of minimally invasive surgery, we have a lot of good boys who are interested in upper GI and lower GI. That problem is over.
It's over.